Welcome to The Explainer. Today, we're tackling a sound that can make any clinician's ears perk up, the heart murmur. We're going to turn that moment of uncertainty into real diagnostic confidence by building an evidence-based toolkit you can use right at the bedside.
So this is it, right? This is the core question. You put your stethoscope on the patient's chest, you hear that swoosh, and you have to decide, is this nothing to worry about, or is it a sign of something serious? The stakes are high, and your next move really matters. That's why having a reliable method is so crucial.
I want you to start thinking of your physical exam skills as a high-powered diagnostic toolkit. Seriously, it's not just a routine you go through. Every piece of it, what you hear, what you feel, even the special maneuvers, is a specific tool designed to get you an answer. So today, we're going to learn how to use every single one of those tools like a pro. Here's our game plan. First, we'll get into decoding the sounds themselves. Then, we're going to upgrade our kit with some power tools, special maneuvers. After that, we'll use those skills to finally sort out the dangerous murmurs from the innocent ones. And at the end, we'll put it all together into one simple strategy.
Okay, let's dive in and start building our kit. The first tools are all about the art of listening, or auscultation. We're going to break down exactly what you're hearing into 4 key components to give it structure and meaning.
So how do we turn listening from an art into a science? You focus on these 4 things every single time it's a system. First, when in the cardiac cycle does it happen? How loud is it? What does it actually sound like? And finally, where on the chest is it the loudest? 4 simple questions.
And let me tell you, timing is everything. It is the first and most important question. A quick tip. If you palpate the carotid pulse while you listen, the S1 heart sound is what you hear right as that pulse starts. Now, while most murmurs you'll find are systolic, if you ever hear a diastolic murmur, that's a huge red flag. It almost always points to a problem.
Now for my favorite part, onomatopoeia. This sounds kinda silly, but it's an incredible tool. Actually trying to imitate the sound you hear helps you identify it and describe it to others. For instance, the rough, turbulent flow in aortic stenosis creates this really characteristic harsh, grinding sound, something like lub-grr-dub.
And this brings us to location, which gives you the next set of powerful clues. You can see there are 6 classic patterns for systolic murmurs here. For example, if you hear a murmur that's loudest in this broad pattern from the apex to the base of the heart, you should be thinking very strongly about aortic stenosis. That's totally different from one you might hear just at the apex. Where you hear it loudest is a massive piece of the puzzle.
All right, let's keep building. Now we're adding the power tools to our kit. These are dynamic maneuvers. Basically, we have the patient do something that changes the blood flow in their heart, and we listen to how the murmur changes. This is how you really start to zero in on specific conditions.
Now, for these tools to work, you have to use them right. Take the Valsalva maneuver. You need to have the patient strain down, like they're having a bowel movement, against a closed airway for at least 20 seconds. If you see their neck veins pop out, you know they're doing it right. You have to get the technique down to get data you can actually trust.
So why do we do this? Here's the crucial part. When you do a Valsalva, you decrease the amount of blood returning to the heart. This makes most murmurs get softer, but there's one big exception, hypertrophic cardiomyopathy, or HCM. That murmur actually gets louder. This single finding has a positive likelihood ratio of 14. That's huge. It dramatically increases your suspicion for a condition you absolutely cannot afford to miss. Okay, so we've got our basic tools and our power tools. Now we can finally tackle the main event. How do you confidently tell the difference between a dangerous pathological murmur and a benign, innocent one? This is where we stop just observing and start to actually quantify our certainty. And the key to doing that is something called the likelihood ratio, or LR. It sounds complicated, but it's simple. It's just a number that tells you exactly how much a physical exam finding changes the odds of a disease being present. Here's a great rule of thumb. Any finding with an LR greater than 5 is clinically very useful. It's a real game changer.
And this is how you actually put that number to work. It's called a Fagan pneumogram. All you do is you take your initial gut feeling, your pretest probability, you draw a line straight through the likelihood ratio of the sign you just found, and boom, it points you to your new, updated post-test probability. It's a visual way to see just how much one good exam finding can change the entire picture. So here it is, side by side. This is the cheat sheet. On the left, you've got the reassuring 7 S's of an innocent murmur. Things like it being soft, short, and sensitive to position changes. But on the right, these are the red flags. A diastolic murmur, one that's really loud, or, as we just learned, one that gets louder with Valsalva. These are the signs that should make you sit up and pay attention.
All right, let's put everything we've talked about into one practical, high-yield summary. Think of this as the ultimate cheat sheet you can run through in your head when you're with a patient, helping you make fast, smart, evidence-based decisions.
This table is the highlight reel. This shows you the most powerful findings from your entire exam and their diagnostic weight. I mean, look at this. Feeling a right ventricular rock for tricuspid regurgitation has an LR of over 31. We already saw the Valsalva for HCM as 14. These aren't just subtle hints. These are powerhouse diagnostic clues you can get right at the bedside.
So, what have we packed into our toolkit today? Well, the big takeaway is that a systematic physical exam is an incredibly powerful diagnostic instrument. When you systematically break down what you hear into those 4 parts, use maneuvers like Valsalva as your power tools, and understand how likelihood ratios turn your findings into real data, that is how you confidently know when to worry.
And that really brings us to this final question. You know, in an era of echo and CT scans, what is the true power of your stethoscope? Well, it's not just a tradition. It's a sophisticated, evidence-based tool that lets you make rapid, high-value assessments right there with the patient, guided by the best tool you'll ever have, your own clinical reasoning.